Welcome
Sorry,
everyone
Josh.
to our welcome everyone to our May 2024 EMS Interoperability Task Force call, where our topic for today will be looking at the data that's needed by EMS clinicians as they respond to a call to treat a patient. So we have covered a lot of ground over the past year plus. After today's call, we will have addressed all the topics that we had on our slate. We have decided to have a wrap-up call in June and have a few things that we think would be good to cover in that call. So for today's agenda, just these two things. We're going to look at this main topic of the patient information that's needed by EMS on a 911 call. That's going to be the bulk of our call today. And then at the end, we're going to take a few minutes to talk about the agenda for this call that we're going to have in June, as well as the future of task force activities for this task force. So that's what we're looking at for today. We're going to go ahead and just dive into today's question. So the question we're looking at is, what information does, before I dive in, I forgot. I always like to just take an opportunity for anyone who has not been on one of these calls before to introduce themselves. Do we have anyone on the call for whom this is their first time on the call?
Hi, Josh. It's Maria. It's not my first time, but I have been away for a while. So I don't know if you were talking about me or not, but here I am.
Okay, great. Thank you, Maria. Yeah, we'll look forward to your input as we talk especially about advanced directives. So thank you. Anyone else? Okay, I think I recognize everyone else's name as having been here many times before. Okay, well, let's jump in. So today's question, what does EMS need on its patients when responding to a 911 call? So in our sequence diagram, we're looking at this area that I've highlighted in yellow at the beginning of an EMS call. As EMS responds to the call, they figure out who the patient is, they kind of figure out their identity, and then they may query a health information exchange or health information network to find relevant information about this patient that would help them to treat the patient. And of course, in this scenario here, we're always keeping in mind the fact that EMS is often responding to an emergency situation where it's time sensitive, or at least they don't have a lot of time to prepare. They're going to be on the scene with the patient and immediately starting to assess and treat. And so any information that they do receive about this patient needs to come quickly, and it also needs to be not too much information. Just the stuff that's pertinent for them. And so that's a little bit of what I want to dig into today. So I reached out to, many of you contacted me and shared with me your lists of the information that you think would be important for EMS to have as they go on a call. So I really appreciate all the input from many of you on this group. And what was cool to see was I think there was a lot of consistency among the different lists that all of you shared with me. So that was really cool to see that I think we have some pretty good consensus on a lot of these things. So I'm going to quickly show you the three lists that we're going to kind of be looking at and discussing today, and then we're going to go back up to the first of the three. So the first one is demographics. Just basic info about the patient. So I included things I heard from you, like their name, their address, their current healthcare providers, and their preferred language. So we're going to come back and discuss that. Then I listed two things under the clinical list for critical information, one being advanced directives like DNR, portable medical orders, POLST, and pertinent medical history, or in other words, diagnoses that are currently being treated for that patient by healthcare professionals. And then I have a longer list of additional clinical information that we're going to look through and discuss as well. Allergies, medications, recent vitals, ECGs, and healthcare encounters, diagnostic tests, recent procedures, and barriers to care. So those are the three lists. So I'm going to pop up to the first of them, and we're going to start with the demographic data. So this is what I heard from many of you, that It'd be useful for EMS to have this information as they're responding to a call: the legal name, the current address, current healthcare providers, and preferred language. I wanted to see if any of you have any comments or insights on this list of things that would be helpful to EMS, either on like what should be on the list or should not be on the list, or why it's helpful, when it would be helpful for EMS to get the information, any of those considerations. So I'll just kind of pause here and open it up and see if anyone has comments on this list.
Josh, I like the list. I would probably add a date of birth to this as well. So when we're arriving at a hospital, 2 John Smiths, the date of birth would be that additional identifier to help separate which one is which.
Great. And then of course that helps you know their age, and that can help you treat them.
Yeah, I would agree with the date of birth from a patient matching algorithm perspective. And possibly gender, although that can really be tricky, right? But I think if you're going to surface information, you're going to need a few key points of data. So when you say legal name, I would suggest that a suffix is not a nice to have. It is a must have. You need to know whether you're treating the father, the son, the baby, etc.
Maria, this is Matt from Note2. I think this is outside of patient matching, just to be clear, because there's 2 sets of demographics. There's demographics that are in the header of either the direct message or the query that gets sent, and that's used for patient matching. Demographics is particularly used here, and is particularly used in US CDI, is different than the demographics used for patient matching. And the reason I call that out specifically is the use of gender. Gender has been a pretty hot topic, and for demographics, we have US CDI and others have made the sense of preferred gender and stuff like that known. For patient matching, that's still even today only includes male, female, or undifferentiated as part of the administrative gender, which is sex assigned at birth. And so I do want to make sure that we're talking the same language when we're talking about demographics, because I absolutely agree. It's important to know whether you're treating the father or the son. It's also important to know what the patient's gender is, so you can call them by the right pronouns, for example. And that's going to be different between demographics that are in the document and demographics that are in the header itself. So I just want to make sure that we're all on the same page there.
Yeah, those are interesting considerations. And one thing I'm kind of wondering about is, we're looking at what's the information that EMS would like to get from the network. But it seems like there's a certain amount of information that EMS needs to know up front in order to even query the network in the first place, right?
Right. And so that's the idea behind this, is that I think what Maria is saying is the fact that there are very specific things that you need in terms of legal name and current address. And I think that's what she wants to lay out there. I think pointing to, or at least understanding what the US AT standard provides, because that's been evolved into TEFCA, and that's a pretty good standard for how folks are doing demographic matching today. So that would be before you would even get the patient's information. You would need all that information and formatted correctly, et cetera. And then when you actually have the EMT looking at the computer screen or whatever, the first thing they're seeing is legal name and making sure that they have the right address and making sure they have the preferred language and all that. I think that's important as that second step.
Okay, thank you.
Josh, I would say current address. That demographics probably shouldn't be current address, but should be last known address.
Last known. Okay.
Because we may very well be picking up at the current address, which is not the last known address in the system.
Right. Okay. Thank you.
And there are fields for previous address within USCDI if folks are interested in that, but I would assume not.
Yeah. Okay, great. Other comments on the demographics part?
Yeah, just the one I put in chat. Make sure you saw it, Josh. That you're only going to get preferred language from USCDI version 3 up, which means that folks are only supposed to certify on the certified EMRs, I believe, by 1/1/26, and have that available. So you're not going to get that today in every case, just to be clear. In a lot of cases, you still are, but not every case.
Okay.
Yeah, I mean, preferred language is nice, but ideally, by the time we have the information required to do the matching, we probably already know their preferred language.
So I might push back on that one a little bit as a clinician and know that I can get out there. I only know and can recognize a handful of languages. And if I'm trying to use a translation service, it really is beneficial to know what I'm asking for from what translator I'm asking for. And I may not know that.
Yeah, so you might know that you need translation. You sense that that English is not their first language, but then figuring out what that language is that would be easiest for them might be beyond you without some additional information from the network. Okay, well, great. Any other comments on demographics? Okay, let's move to clinical information, which as you saw, I broke it into two lists, and I have this very short list that I labeled critical, just based on input I received from people. So this is open to modification. And then that longer list that I labeled for additional clinical info. And the stuff that came up as critical seemed to be these two things here. Advanced directives, which are going to have, a direct impact on the care you may provide or refrain from providing for that patient based on those directives. And then pertinent medical history being diagnoses that are currently being treated, active diagnoses being treated for this patient. So I want to start with advanced directives. Get input from everyone on yes, no, that this belongs on the critical list. But also, I'm also kind of curious about the current state of things with advanced directives in terms of their availability, how people are going to be able to get them today, especially over networks. I know in the past, it's even been things like, you put the vial in the fridge and it's sort of those physical means, non-data driven means of providing an advanced directive. But I want to open that one up. In particular, I know we have Maria with us from My Directives. So we've got some good expertise here about advanced directives. I want to just learn from all of you on, what these look like. And yeah, I'll pause there and see what everyone has to say.
Thanks, Josh. I don't want to step on what anybody has to say. For a frame of reference, I have been leading the HL7 standards development project that is building on the CDA standards and looking to develop FHIR implementation for advanced directives, advanced care plans, portable medical orders, and we have recently added mental health directives because of the behavioral health crisis that we're faced with. So, I would suggest that in the realm of EMS, we probably want to focus on portable medical orders because those are really the only documents that EMS can heed under a safe harbor provision that can stop care from being delivered or completely green light, emergency measures from being delivered. I will tell you my project is sponsored by CMS and the Office of the National Coordinator, and there is an extreme interest in the first leg, the last leg, if you look at adoption, the first leg of the journey to involve EMS. You guys are, EMS is the first responders. If we've done documents to inform care and EMS doesn't have access to those, we're adding to the 65%, mental health problem rate that EMS has. We are hiding information from them that was never meant to be hidden from them. And I think, regardless of where the industry is at, because they've come by leaps and bounds further than they were when I started pre-COVID, I think it's really important that EMS has access to at least portable medical orders and can start or stop care to honor the individual.
Great, thank you. Yeah, and then Matt just put in the chat the link to US CDI version 5, which is in draft status right now, which has added a section for advanced directives. So that's great to see that that's coming into US CDI.
So if I can jump in, Josh,
Yeah.
Maria, thank you so much. It is, as a clinician, I love seeing this come forward. My only comment I would add to this is I cannot wait to see this in our patient hand or caregiver hands, because we usually have seconds to make decisions about starting care or terminating care. That being said, at least in the state where I work in New Jersey, the only forms we can honor on a basic life support level are DNR and PULSE forms. And at the ALS level, we can honor those immediately, and anything else we need to consult with medical control. So we just need to balance, the basic forms versus the more advanced and in-depth orders.
And I couldn't agree more, Dr. Thorne. That's what I said. It's the portable medical orders. I think I don't want to obscure data. If somebody's created and executed a properly witnessed and notarized advanced directive, I think that that's helpful to EMS. But in most states, it will not impact the emergency care that they deliver. That is contrary to portable medical orders. If I've executed a DNR, DNAR, EMS comfort care, if I've got a PULSE, the MOLST, the TPOP, whatever combination of letters works in your jurisdiction, those documents were created to stop or greenlight or inform emergency care. And if EMS isn't a part of it, then what are we doing to the EMS responders? We're creating a huge emotional burden for them, not to mention all of the other falderall that follows in the way of litigation and a complete inability to do the best possible job they can do as clinicians.
In terms of definitions, I want to be clear in my mind. If we look at the terms advanced directives, DNR, PMO, and PULST, is it the case that DNR and PULST are both considered forms of PMOs, which are considered advanced directives, or like, is there a kind of a hierarchy of definitions there?
Oh gosh, if you knew how many times I've had this conversation over the last 3 years. So we actually took the term from our very own Mickey Tripathi, who refers to, because you got to figure a guy who's in the know, but isn't as close as the rest of us are, whatever way he labels it might be worth leveraging and replicating. He refers to the entire body of advanced healthcare decision documents as advanced healthcare directives. So within advanced healthcare directives, there are the things that I can do as a person, and those are advanced directives or advanced care plans. There are the things that practitioners write, and they have teeth in them, and they're actionable, and they're protected, and those are portable medical orders. And those are the largest overarching categories. Although, as I said, we just got funded the handle mental health advanced directives, which I would imagine most EMS responders are interested in those as well, since they have emergency treatment provisions. Does that help, Josh? I could give you like a document ontology that gives you a real simple view.
Yeah, I think that would be cool just for our documentation purposes. But yeah, thank you for that. Okay, and then I'm curious if anyone has insights on just the availability and prevalence of these documents on current networks today, either nationally or in HIEs. Are we seeing that these are becoming available? How widespread is the availability over current networks?
I mean, again, I can tell you what I know, but I don't want to dominate the conversation.
Yeah, tell me what you know, and we'll see if there's any other comments too.
And we'll go from there. Okay.
Yeah.
Okay. So there are a number of states that, in conjunction with their state health information exchange, and you've got New York and Texas and California, and they've got like 5 or 6 HIEs, but there are a number of states, Oregon, Idaho, Maryland, Maine and Michigan. There are a number of states that have understood the outcry following COVID and have either partnered with or worked with organizations who have registries and repositories that surface these documents. And most of them are surfaced to inform emergency care because, you know, that's when minutes matter and seconds count. There are national registries and repositories that are also available. And what we're seeing is more and more state registries are like, you know what, I got traditional health information, but my providers and my, you know, constituents, they want these documents. And so there's a massive upsurge of development and interest on the part of taking this stuff to the last leg. The ONC is looking at grants to say, you know what, we've gotten this far, and we know we can liberate them, and we know we can rip them out of EHRs, and we know we can make them available. And people can be their own advocates, and they can give you digital access or paper access. But if EMS isn't in the loop, we're missing a beat. So there is an extreme interest on the part of CMS and ONC to see if we can get the last leg of the stool looped in. So whatever is there right now is not where we need to be, but we should not ever stop looking at the art of the possible and setting forward motion that the industry is simply waiting to adopt.
Yeah, thank you. What are some of the others of you seeing, you know, any of you getting access to these documents?
Within our clinical arena, the only place we're seeing it exists in our medical record already. It's from prior contact. Otherwise, we have no way of getting this.
Okay. This might be maybe a question for Matt Becker. Are you aware of these documents being exchanged on national networks? And if so, what kind of standards are being used?
Hey, Josh, I think Matt had to step away for a second.
Okay.
So here's what I can tell you. Chris is accessing the Chesapeake Regional Information Service Provider. Chris, Maryland is accessing them on a national basis. Washington, D.C. is accessing them on a national basis. I can tell you that the D.C. Fire and EMS Foundation is working to deploy them via the Rush model in Washington, D.C. That is also being deployed in Massachusetts in conjunction with the Mass Highway. Delaware, the DHIN, is deploying them. Hold on, I'm going through my list. California is always up to something. So they're deploying them in different areas, and they're trying to do it across the state. Colorado has deployed them. Idaho, we're working with 2 of the HIEs in New York. One of them is working under an ONC grant to do exactly what I just described the ONC wants to see, which is to get them in the hands of EMS. Louisiana is doing it. Oregon is doing it. UPMC in Pennsylvania is working on the Rush model, which gets them in the hands of EMS. 2 of the Texas HIEs are doing it. Virginia gave birth to the Rush initiative with the Hero Kids Registry, and Michigan is doing it as well. And I'm probably missing some states.
Okay, cool. Matt, I saw you, I think you got back on the call. Just had a question that you might be able to answer. I was curious if you're seeing these advanced directives or portable medical orders being exchanged over national networks today.
Not yet, no. So folks are adding it for the US CDI version 5 measure. I know that some of the EMRs are working on that. But at the same time, it's not being exchanged in nearly all queries today, because those queries are going specifically to the site that holds those that pieces of information on the EMR on the national network. So when you go to the EMR directly, it's really contingent on what the EMR provides, which is not USCDI version 5 data yet. And so you might see an advanced directive statement and a note or something like that. But as far as discrete forms or discrete data with advanced directives, in the vast majority of cases, not yet.
Okay, thanks. All right, anyone else with comments on advanced directives? Cool. So that sounds like this super important piece of information that EMS needs, that definitely needs work to be widely available on networks today. Let's move to the second one on this list, the pertinent medical history, being diagnoses that are currently being treated for this patient. So, they might have a current active diagnosis of diabetes or, whatever it might be. Any comments on that one?
Gosh, I'm just curious, what are we, how are we determining what's a currently being treated condition?
Yeah, good question. As I understand it, the way the standards work, you can have, like in a continuity of care document, for example, you could have a list of problems that patient has. They could be coded using ICD-10 or SNOMED or other codes. And each of those diagnoses can have, or problems can have, a start date and an end date. If they don't have an end date, then that would imply that they're that's a current diagnosis. That's my understanding of it. I don't know if anyone else has some experience that could shed light on how we would identify those. And I'm going to come to the question of like pertinent and recent after we look at this second list as well, because I think that's worth coming back to. But let's move to the second list here.
So yeah, and the pertinent
ahead.
medical history, I guess my question back to you would be, if it's diagnosis currently being treated as that as a definition, is that seems to point to the problem list to me. And because diagnoses that are permanently on a patient's record are just problems on the problem list, and they're both ICD-10 encoded. I guess my question is are you not seeing the problem list as accurate? Are you not seeing it updated enough? What does currently being treated mean? And where is the gap in actual practice today? Because I realize what is available in the technical and is supposed to be perfect, but understand that is probably not.
Yeah, Art, any thoughts on that? I don't know if you have some, particular experience of things you've seen.
Yeah, was just kind of curious because sometimes we see things on a patient record, particularly from another facility that may have diagnoses that are either not currently being treated or may not be pertinent to what we're currently seeing. Pertinent down the road in the care for the patient, but may not be pertinent for EMS.
Oh, okay.
And the question would be if that list is extensive, does that actually hinder the ability to get meaningful information to EMS if we're looking at an extensive list of things?
Yeah, so two things I want to distinguish here. That's a great point, Art. Thank you. And before Neil, I know you have your hand up. The piece I want to distinguish is the problem list versus diagnoses. So when you get data from other organizations, you're typically going to get either via push or via poll, you're going to get both a patient level summary of their current conditions, which is a problem list, which just should be what you need. But each individual encounter document that you get for a patient, which could be included in the patient level CDA if it's push, especially, is going to include individual diagnoses for that encounter. What we've typically advised people, and I'm here to obviously get opinions on this, is to ignore the diagnoses in terms of displaying, especially in EMS, and focus on the problem list, which should be a current list of ongoing issues that correlate to the diagnoses. But curious to hear what others think. And Neil, I'll let you talk now, I promise.
Thank you, and sorry, not to derail this, I just wanted to throw one other point in. I agree wholeheartedly that problem list, the way it was described, is perfect. I would just add there's actually one item I think needs to really be bounced up to the critical list that isn't on the lower list, and that's allergies, medication allergies. Because if I'm thinking that if demographics, I get the critical information, and then I get the second set of information in that critical list, I may give a patient a medication that has a bad reaction, negatively impacts them if I don't know that piece of information.
Mhm.
The rest I can work around, but that's one very critical piece of information to get along.
Great, thank you. Good. Yeah, that's some good discussion. Good things to think about. I'm just thinking about like, I don't know. I cut my leg with a saw last summer. If you were to get a continuity of care document, it might include an encounter that I had where I was diagnosed with a cut in my leg that got sewn up. But that could have nothing to do with the reason you got called on the EMS call today. And so I think that's what we're saying here, is pointing towards the problem list being more like, here are the medical issues that this patient is experiencing on an ongoing basis. Okay, let's go to this second longer clinical list. Neil has already taken allergies at the top of this list and said, hey, that should be, at least medication allergies should be critical info for EMS to know right away, so they don't accidentally or incorrectly administer a med that's going to cause a bad reaction for that patient. So I've noted that, and I'll let you all look through the rest of this list and see if you have comments in a couple of ways. One, are there some things on this list that really need to be kind of more on that critical list? And are there some things on this list that maybe would, it would just be too much information, maybe it's cool info, but EMS just doesn't have time to process that information, and maybe we shouldn't prioritize it. So, okay, yeah, so I'll open it up here, see if you have comments on anything on this list.
I would suggest that a prior history of behavioral health issues is important. We certainly would want to take somebody into the medical system with a behavioral health history that deals with addiction and load them up with morphine when there's an opioid sensitivity.
Yeah, behavioral health issues will be on the last page on the critical items of their problem list.
Okay, so I'll make note of that, though, that problem list should include behavioral health
any sign of so things it'll cover is drug abuse, it'll cover depression, anxiety, all that stuff.
Okay, I know there's sensitivity in law, there's sensitivity around information that can be released about mental and behavioral health.
Right, and that's only from a 42 CFR Part 2 covered facility. Sorry to interrupt, Josh. Specifically, if it's on a patient's problem list at St. Luke's, for example, here in Idaho or wherever, it's still going to transfer over, even though it's a behavioral health quote unquote issue. 42 CFR Part 2 only tends to cover specific substance abuse facilities and information released from there.
Oh, got it. Okay. Yeah. Information about that facility's relationship with the patient.
Right. So like the actual drug abuse will generally appear on the problem list. But again, there's probably some sensitivity towards that, and some folks may hide it, but it's the wrong thing to do. And the industry, in terms of interop, is just kind of acknowledged that is the wrong thing to do. And we should be sharing that information across groups because it's not generally accepted as illegal.
Mm-hmm. Yeah, and clearly, I mean, we just had Maria's example of how it's pertinent to EMS and how they can help protect the patient. Yeah. Matt, you had put in the chat with ECGs, are we looking for the actual ECG image or just the interpretation of that image? Anyone with thoughts on that?
Yeah, are y'all reading the P-waves and stuff like that? Because that's going to be two different kind of things.
I would just say that I want to see the image to be able to compare to what's currently in front of me. But the read is also important.
Okay. The image is
Yeah.
harder, and the image is probably further away, but that's a good point.
Yeah, the image would be important. And just, I'd say that, if we're bringing over allergies, medication allergies to critical, which I agree with, I also think medications should probably be there. Particularly if we're dealing with, patients who don't know what their current medications are. Sometimes that determines where we're going with what we're going to administer. So,
Okay. Yeah, so they're currently taking a particular medication, and that could have an interaction with something you might decide to administer to them.
or could determine which way we're going as to giving them more. So, yeah, it would be good information to have right away.
Okay, yeah, good. A couple notes on medications. There was a pharmacy interoperability task force under the Health Information Technology Advisory Committee, HITAC. And that task force came out with some recommendations last year about improving interoperability with pharmacy data. And we're going to have someone from the Office of the National Coordinator fill us in on that side of things. They weren't available for today's call, but they'll be with us in June. So that'll be interesting to hear about. And then I'm curious if any of you have thoughts on, I put in current medications, prescribed medications, dispensed medications. I have heard that there are, these differences between maybe what was prescribed to the patient versus what they got filled or dispensed, versus what they're actually taking. Of course, there's only so much information you can get from a network or other providers about what they're actually taking at home. But I wonder if any of you have thoughts on are there important distinctions there between prescribed, dispensed, and so on? Okay, maybe not. That's fine.
So Josh, sorry, I
Let's see.
paused a
Yeah.
minute to let other people jump in because I know
Oh, yeah, no problem.
so my apologies. I think dispensed would be all of it is very beneficial, but I think dispensed is the mode that, if you had to rank them, would be the number one on the list because it's the closest to understanding what they're actually taking, what's prescribed versus dispensed if they didn't fill it. Yes, that's pertinent as well as what may be untreated in their medical history, but knowing what they're taking is probably the highest on that list.
Okay, thanks.
Yeah, I would absolutely agree.
Okay. All right, I'm trying to see if there's anything in the chat we need to bring out into the discussion here.
Hey, Josh.
Yes.
Jonathan. I got a note from someone that there was a discussion around end of life orders, pulse, etc. Is that something that I missed? I apologize for being late. I'm bouncing through things today.
Yes, we've been talking through the information that's important for EMS to have at the beginning of their call. And I'll back up one slide here. We had put those advanced directives or orders as kind of top of the list on the critical list.
Great.
Of things that are going to immediately impact EMS care. Yeah.
Good. And so was the suggestion that they are being communicated, they're not being communicated, they need to be, or what was again, I apologize for going back. But
no problem. It sounded like there's a bunch of places working on making these advanced directives available to EMS through various networks around the country, that they're not advanced directives is just now being added to US CDI. It'll be in version 5.
Yep.
And so it'll be a year or two down the road to see implementations that are US CDI based. And that's probably when we'll start to see these more on national networks, for example, within TEFCA or Care Quality. So that was kind of the summary.
All right, so let me just clarify two things. So using two examples, one being Oregon, the other being CRISP. Of course, CRISP is very well connected in a variety of places, I believe. And Maria, you can correct me if I miss any, but I believe you got Maryland, Delaware, Virginia, West Virginia, Connecticut, Washington, D.C., Alaska, and soon to be South Carolina, from what I understand. So that's quite a few states in there. They're all on that network. They utilize a system called My Directives, formerly AD Vault, as their Pulse provider. And that we are actually working, BLT specifically, is working with My Directives to enable crews to access those data using a very similar mechanism to what we're doing across Oregon. Across Oregon, there are about 6 fire and EMS agencies that access pulsed forms in the field today. So they are absolutely able to receive those at the patient's side in real time. And we did orient that that data transport, the mechanism, the interoperability, or the framework, I should say, around Nemesis. It was actually very specific and very important in terms of ultimately allowing those data to flow through to a chart.
Okay,
So hopefully that's definitive enough.
Yeah, thank you.
Yeah, Abby Dotson, who's the director of Oregon Pulse Registry, voluntold me that as the folks who run the registry in that state, that we will be participating with the HL7 IG process around delivering pulsed forms to crews, facilitating bidirectionality and working with the HIE in that state as well. So we are engaged with the Reliance HIE. They are actually currently looking for EMS agencies. So this would be actually a more shout out to John and the folks from Image Trend in particular here, that they are looking for folks in Oregon, whether that are utilizing EPCR in the field ideally, but in general that want to send data to the HIE. There are presently there's literally one charting system that has currently interoperated with the Reliance HIE, and that's MetaView. But we don't operate on the ground in Oregon right now. We're working on some things, but right now we are not in the crew's hands for EPCR. So they are looking at EPCR agencies that have an interest in interoperating with that HIE should raise their hands. That has been a long sought objective they have not yet achieved in Oregon. But the way that this system is structured in Oregon is that the Reliance HIE can ping the registry. And so to the degree that you can have these 3 systems, EPCR, HIE, and Pulse Registry, essentially speaking to one another through APIs, that is allowed in Oregon, and that will affect a similar objective to getting the data transported through without the crew necessarily having to go log into third-party systems to get it. Hopefully that's definitive.
Okay. Yeah, thank you.
Sure.
All right, so I'm going to come back to our list of additional clinical information here. Let's see. Yeah, other insights, questions, things we need to dig into on this list of items that could be important to EMS.
Hey, Josh, I guess this goes back to kind of the current conditions, but the recent or pertinent surgical history. How are we defining pertinent?
Yeah. So you guessed my next slide.
Okay. All right.
Which is just one question with 2 words. What's pertinent? Yeah, so I'm going to come back to this list now. And I want to open that up for some discussion, because I think that, it's critical here that EMS gets information that they can immediately act on, and that they don't get too much information. And my fear really is more on the side of getting too much information, that they just get this barrage of, for example, if they were going to start reading through continuity of care documents, that's just infeasible. EMS needs something summarized that says, hey, here's what's important, probably for your call. And I'm wondering if you all have thoughts on how, like, what are the considerations, the rules, if you might, about deciding what information to surface for EMS from the whole pile of stuff that's available? How do we determine pertinent or even recent? So yeah, thoughts on that question?
I mean, hey, I don't want to dominate, but we've spent a lot of time thinking about this. So to the degree that you want to have some discussions offline about some specifics, Josh, I'm happy to. We again, but whether focused on children with mental health needs, um, focused on delivering the pulse, or focused on post-crash care, we are doing a lot right now of essentially looking at the USCDI side, looking at the NEMSIS side, doing a gap analysis between the two, having interviewed folks all over the country about essentially which pieces of data are relevant. In some cases, we're actually appending. There are data points that are important to them that are not in NEMSIS. I'll use an example of blood type that has come up a lot lately, especially with the delivery of whole blood in the field. There's just not enough type O blood to go around. I actually did a interview at FDIC with the EMS medical director of Indiana, Eric Yazel. And there we were talking about trauma care and the various types of blood. And even if you have an individual, for example, with hemophilia, who may need a clotting factor to go along with the blood. So to the degree that those are data elements that are important to people but are not in NEMSIS, but do have locations in other parts of the HL7 ecosystem, that we're sort of merging those two based on these critical use cases. Again, I don't want to bore the group with all of those details now, but a lot of that work has been done. A lot of that work is at scale already and really doesn't need to be reinvented. So I'm happy to talk to you about sort of what's in those, what incorporates NEMSIS, what goes beyond NEMSIS, and again, how that orients with USCDI and the CCDs.
Yeah, feel free to share some stuff with me afterwards, especially anything that you think should get more widely published,
Sure.
shared publicly. Yeah.
Sure. But by the way, just so you know, this work has gone back. I mean, I know this collective has its pace. But a lot of what you're actually looking at here actually goes back to 2014. Some of this is almost 10 years old. And it was funded by the California Healthcare Foundation. So there's a lot of work already done. I'm happy to put that on the record here. That while I'll never suggest we shouldn't do it, I do, this for me, I always get nervous of the idea that we're reinventing the wheel, promulgating silos. There is a lot that's been done. California has been doing a lot. And to the degree that anyone here isn't familiar yet with the California Data Exchange Framework, they have established a lot of groundwork already for this too.
Okay,
so I'd suggest looking here.
Yeah. One of the things, as people were submitting lists to me, if we look at things like ECGs, I think someone had said, the 3 most recent ECGs. I'm wondering if people have thoughts on that, or is it like we want ECGs that have been obtained within the last, X number of months? What's relevant there?
I would say,
go ahead. I'm sorry.
no, that's right. Go ahead.
I'd say the last 3 is beneficial to not overload the system. The challenge just becomes for a patient who may be recently post-STEMI, where they may still have abnormalities as opposed to a baseline, or where there's current critical event changes that may require going back a little further to get to a more baseline.
Oh, okay.
And if we do a cutoff date, that may preclude patients who haven't had one in, let's say, 4 or 5 years.
Yeah.
So yeah, that's a challenge.
Yeah. Okay. So it's almost like you'd like to see whatever's most recent from their ECGs, maybe 1 or 2 or 3 of those. And then, if the software was smart enough to give you the most recent that would have been considered baseline for that patient, that it might have been 2 years ago, but that was their previous baseline. How about on surgical history? I think Art, by email, you had mentioned to me that oftentimes you see procedures that just aren't helpful to EMS. I mean, patients have had all kinds of different procedures done on them that kind of have nothing to do with the reason they called 911. And I'm wondering, your thoughts or other people on the call, what you've seen in terms of surgical history, procedure history that's been useful versus being just too much information or irrelevant.
Right? Yeah. Um, it's kind of this again, another rougher question, but procedures that are kind of how would I put it, kind of like one-off procedures that are not necessarily anything that requires follow-up. We have, back in the days of paper forms, patients still do, right? They have those forms at home that list their surgical history, and it includes the hernia repair from 1974 and their appendectomy from when they were 6 and they're now 84. So I guess it's, my concern is that, well, some of those things may be important for other things at the hospital, that it creates a list that's overwhelming to the provider. And if that list is too long, they're not going to look at it. That's my concern. And I'm not really sure, I kind of leave this up to other people in the group who have seen is how do we curtail that list? I don't know.
Yeah, Neil, is there anything you've seen in the integrations you have in place around past procedures and things like Neil's talking about here with stuff that's, not real relevant to EMS?
I don't really have anything pertinent I can add to it. It's a catch-22. We want all the information, but we don't. But then we get all the information and we're like, okay, we don't want all this. So
exactly.
I mean, kind of going back to the active procedure list. I think Josh, you were the one that said, is there a time frame on it? And again, maybe it's a truncated where you get the first pushes. Here's what's listed as active in the system. And then after that, it becomes, you can access the full list, kind of a tab based or something like that.
Mm-hmm. Dig deeper if you feel like you need to.
Perfect. Yeah. Good description.
Yeah. Okay. Yeah. Anyone else with this, with perspectives on this question of what's pertinent and how we help to not overwhelm the EMT with information? Okay. Well, at least things for you all to think about, especially as you're implementing interoperability. Doing some good system design. Obviously, with interoperability, our goals here at the national level are to identify the standards to use, identify the information that should be shared, and then those of you who implement this get to grapple with these finer tuned questions of system design and how you're going to really prioritize what you show to EMTs and help them with their decision making. Okay, so that was the what's pertinent question. All right, so did we answer today's question? There's a QR code here for the post-call survey for this call, just like all previous calls. We really appreciate you taking a few minutes to just fill in that quick post-call survey to let us know if we covered the topic adequately today and if there's other things we need to consider covering. And Lisa, if you could put that link in the chat as well, that'd be great.
Hey, Chuck.
Okay. Yes.
Sorry, I didn't ever see the hand. Just one other thing you asked on the last slide before you part. Yeah. If I may make one piece of sort of advocacy or zealous request, I think your question is a brilliant one and one that a lot of people wrestle with. I've had numerous conversations over the years, not only with you, but with Eric, with Gam, with others, about how the biggest gap that I see is the education to the crew around the why, right? And Maria and I certainly have talked about this a lot too. There is a real downside to the crew on a daily basis to not getting access to certain pieces of information, particularly things like Pulsed. I have simply described it as mental anguish. I mean, we talk a lot about burnout. We talk about the post-traumatic stress. And there is something to be said for finding out later that there was something in that information that you wish you had had at the time. And that is not effectively communicated today to practitioners in the field, right? When we think about, there are states that have double-digit percentages of agencies that still don't even chart until they get back to their station, but they don't even touch technology because they figure it's a distraction. And it can be, right? That's not an irrelevant statement, but tucked inside of that technology that's irrelevant could also be something extremely relevant, right? Like finding out that the kid is a hemophiliac or that the patient had a pulse. So I think there is a broader conversation not being had that is really essential to the well-being not only of the patient, but of the provider. That if you are going to do the best job you can and don't want to find out later that you missed something crucial, right? And that you did everything right and the patient died because of the thing you didn't know. But we need to have a conversation around how the end users start to ask or be explained why this information is relevant. Because I think this is a bubble, right? Right now, we're in a technology echo chamber for everyone on this call. But the stakeholder group that's not represented is the folks who are going to have to do the field training and explain to the crew that this is not busy work. It's not about billing. It's not about legal. It's about making sure you know everything you need to know in order to provide the level of care you're trying to provide. And again, and the downside if you don't. And I think particularly when you start looking at older patients, polychronic patients, CP patients, this becomes really critical to what is in your record. Like you say, it's not overload, but it's also enough that you're not going to do the right thing and get a result you don't expect. And I just think that's a longer discussion with NSEMSO next week, right? Recognizing that we need to start to have some of these discussions around how we're educating people, not only on the tech, but why the tech is relevant to their clinical practice. Anyway, that's it. Thanks.
Yeah, thank you. All right, I want to switch gears here for the last little bit of our call. We, as I mentioned, are going to have a wrap-up call on June 13th. I appreciate a couple people who shared their thoughts with me about what we might cover on that call, plus a couple other things we've identified. So for that wrap-up call, we're going to have an update on pharmacy interoperability for current dispensed medications from ONC, as I mentioned. We'd like to give an update on next steps for getting outcome queries supported well within TEFCA. So we're going to work on that. We also want to spend a little time talking about barriers to incorporating outcome data into NEMSIS exports. So the concept here being there is interoperability in place in some places around the country where hospital outcomes are coming back to EPCR systems. And if we look at the records from those systems going to the national EMS database, the hospital outcomes are not included by the time they get to the national database. There's some barriers that we've identified, so I want to share that list with you on the call on June 13th and collect any others that you may think of that make that a barrier from getting the outcomes to actually getting them into the NEMSIS export and getting it to the state and national database. So that'll be a topic for discussion, and then what we can do about those barriers. That leads to the idea that there's probably going to be changes to the NEMSIS standard in the future. This will be a couple years out. It'll probably be NEMSIS 3.6 at that point. But as we look at the e-outcomes section of the NEMSIS standard, it has some constraints in it that are more strict than what we see in the actual data coming from hospitals today. For example, where NEMSIS may only allow an ICD-10 PCS procedure code, hospitals might be using a SNOMED procedure code, things like that. So we want to discuss that and how we could make improvements to the NEMSIS standard to line up better with the rest of healthcare for outcome data. And then next steps. So this call on June 13th will be the last of these monthly calls, but it won't be the end of our work on the task force. We'll keep working on it. I do want to see if all of you have additional thoughts on what we've got so far for the agenda drafted here for June 13th. Anything we should be thinking about for including in that call. Okay, well, hearing nothing, I guess hopefully that means that I've done a good job of collecting the input that I have been receiving from all of you on what we can cover in that call. So as I said, June 13th will be the last of these monthly meetings, but we'll continue the work afterwards. So we're going to keep the Google group going for the task force. So issues or topics or announcements that come up, we can use that group to communicate about them, to get input where needed. The NEMSIS TAC has deliverables to work on, to put out guidance and technical resources to help with interoperability. So really taking all the stuff we've learned and documented through these monthly calls and turning that information into products from the NEMSIS TAC that can help you all with your interoperability efforts, turning those into initiatives or efforts to engage EMS more deeply in national interoperability efforts in the rest of healthcare, all of that. So we're going to have a bunch of work that we'll keep doing. I wanted to mention that I will be at the NASEMSO annual meeting next week. So if any of you will be there and you'd like to just get with me and chat about interoperability, I'll be there Tuesday through Thursday and would be happy to spend some time one-on-one with you. Other than that, reminder to do the survey for today's call, and then we will look forward to the call in June. So any parting comments from the group before we go?
Thank you, Josh. Nice work.
Well, thank you. Thank you all for being on the call today and for all the input you've provided. It's just been truly valuable, and I know you're donating your time to this effort, so I really appreciate it. And I look forward to talking with you all again in June. Have a great rest of the day.